and thank you for coming this morning. I hope to be able to show you some information about a really exciting part of my life. I've been here at NYU for 18 years and started doing melanoma when I got up here talking about lots of trials that we thought were going to be exciting that turned out to be negative. And so really only over the last 5 years have we seen such a dramatic change in therapy options that have really changed the life of patients with melanoma. And so I'm very proud and very excited to have been a part of that change, because many of those trials were actually done here at NYU with our patients. And so I'm going to start out with the questions that we're going to finish up with again. Again, this is just to give you an overview of what I hope to accomplish in the next couple of minutes. So the first question is that the most effective treatment for melanoma that has spread to other parts of the body is chemotherapy. True or false? Vertically challenged. And I didn't have the heart to put my heels on today. I brought them, but I left them. All right, so we'll answer these questions at the end. So the second question is approximately 50% of all skin melanomas that spread to other parts of the body will have a B-RAF mutation, and this mutation can be transmitted to other members of one's family. True or false? Next question, the side effects of immunotherapy are the same as the side effects of chemotherapy. True or false? The chance of a patient with metastatic melanoma that has spread to other parts of the body is living 5 years is less than 5%. True or false? And finally, the last question, immunotherapy activates a patient's immune system to attack melanoma. This treatment has a very high possibility of putting patients into remission for the rest of their life. True or false? So we're going to go back and hopefully you'll be able to answer those questions after my talk. So let's talk a little bit about metastatic disease. I'm focusing on metastatic disease because Dr. Hale really focuses on melanoma prevention and identifying primary melanomas. Dr. Berman will be the surgeon to take out the melanoma, and many of the patients who get referred to see me will either have a melanoma that's spread to the lymph nodes, called stage 3 melanoma, and so we talk to them about therapies that may be able to prevent the melanoma from coming back. But many of the patients that I see actually have metastatic disease, which means that the melanoma has gotten out of the skin and gotten out of those lymph nodes and gone to other parts of the body, such as the lungs, the liver, the brain, the bone. Pretty much melanoma doesn't follow any rules and doesn't really care what organ you are, and has the ability to spread to really any organ in the body. Unfortunately, there is really no blood test that we have that will be able to identify patients when their melanomas go to other parts of their body. It's currently research that we're working on here that we hope to be able to have a blood test to say, hey, this particular blood marker looks to be rising. I think we need to look and make sure that your melanoma is still in check. But now I'm going to tell you about some of the really interesting and very, for lack of a better word, almost curative, and we never call melanoma patients with metastatic disease curative, and you're going to hear from one of my patients who I'm going to tell you is in long-term remission, and I tell them that they can be in remission for the rest of their life because I'm afraid as a melanoma doctor for such a long time to actually use the word cure because I've never known that before. But I really think we're getting to the point in our therapies that we're actually going to be able to tell patients that yes, you are now cured from your melanoma. And so patients who in the past had gotten melanoma that spread to other parts of their body had a very, very small chance of ever surviving 5 years. Many of them died within 6 months. Now we have therapies where at least 50% of our patients will survive and go on to live long, productive lives, not having to deal with their melanoma any longer. Many of the times we can give patients treatments that make their disease get better now 75% of the time, as opposed to just 5 to 10% of the time. And prior to 2011, there were only 2 medicines that were approved for metastatic melanoma. One was a chemotherapy by the name of dacarbazine, and the other one was a medicine by the name of IL-2. IL-2 is a immunotherapy, a biologic therapy, and the reason that got approved was because there was a small percentage of patients who got that medicine. When they got it, their melanoma disappeared and really never came back, and we had never really seen that. And because of those very few but very sustainable responses, the FDA approved this medicine as a treatment of metastatic melanoma. Fortunately, we weren't happy with that 5 to 10% benefit, and so many of us medical oncologists continued to do research in melanoma, looking for medicines that would change what happened to the lives of our patients. We knew that chemotherapy was targeting cells that divided very quickly, but it appeared that melanoma was very stubborn and very resistant to chemotherapy, and chemotherapy really didn't work. And if it worked for a very short period of time, but then the cancer started to grow. And so we started looking at the genetics or the biology of why is melanoma such a stubborn cancer. And we found 2 things. We found one, that the immune system really kind of protected the melanoma. So if we could convince the patient's body that the melanoma really didn't belong there, well, just think about it. We can get your body to attack your cancer and not have to give you chemotherapy. In the process, we also looked at the actual genetics of melanoma cells and found out that some of those cells had a mutation called a B-RAF mutation, and we were able to see that this mutation was actually the signal that told certain melanoma cells, keep growing, keep growing, keep growing, and spread and divide and conquer. But when we developed this medicine, which is actually a pill, this pill stops that mutation. It shuts it off, and so there's no more signal for those cells to keep growing. So guess what? If you cut off the signal, the cancer cells die. And so it became a very, very effective therapy for patients who had melanomas that had a B-RAF mutation. So we're going to talk a little bit about all of those therapies. I keep going backwards. Okay. So again, looking at this slide, half of patients will get targeted therapies, and some of the patients will get immunotherapy. Some patients will get both therapies. Unfortunately for us, we still haven't perfected which therapy goes to the right person, but that's what we're working on. We're trying to really find a way to personalize what's the right therapy for the right melanoma so that we don't have to hope that we pick the right one, that we get it right the first time. So when we talk about targeted therapies, we're going to talk about B-RAF mutated melanomas first, because this is the highest rate of mutation that we see in melanoma tumors. 50% of these tumors that Dr. Berman would take out, we will look under the microscope and send the DNA to look at the genetics and see if in fact it has a B-RAF mutation. If it has a B-RAF mutation, it tells us that this tumor has a target that if we shut down that target, we can shut off the cancer. What's very, very important to know is that this mutation or this target is found only within the melanoma cells. This is not a genetic alteration that you can spread to your family, that you need to be concerned. Do I need to tell my children? Do I need to tell my grandchildren? Am I giving them this melanoma mutation? And the answer is no. This is just a mutation within the melanoma tumor that allows us to pinpoint a very specific therapy that will shut down that type of melanoma. The responses that we see when we treat patients with B-RAF inhibitors is very, very high. Again, when we had treated patients with chemotherapy, it would take months and months and months before we would see anything, if we saw anything happen. When we treat patients with targeted therapies or B-RAF inhibitors, the response, again, because remember, that B-RAF mutation is the signal telling these cells, keep going, keep dividing, keep moving. If we block that signal, things get better very, very quickly. And so much to our amazement, when we did these very first studies here, we handed patients bottles of pills and said, take these pills and come back next week. Well, I can be perfectly honest with you, I never imagined what I was going to see when I handed the very first patients who did these studies with us what their responses would be. They came back a week later, and almost 50% of their tumors had improved, or their pain got better, or they started eating, and everyone, hands down, would come in and say, my God, I don't know what you've given me, but boy, do I feel good. And look, my tumors are gone. And so it's a very, very fast-working medicine, which makes it very convenient for us when we see people who are very sick. And if their melanomas have a B-RAF mutation, we have this medicine that can make them better very, very quickly. And many times, I get phone calls from patients that are in intensive care with tumors that they don't know what it is, and all of a sudden, we get back a B-RAF mutation, and they call me and say, hey, listen, we just found out this patient has B-RAF mutated melanoma. They're not really doing good. Can you help them? And a true story, went to see this patient in the intensive care unit on a Friday afternoon. He was ready to get put onto a ventilator because the melanoma tumors were essentially choking out his lungs. And by Monday, he went home. We shut off the signal, the melanoma stopped growing, the patient got better, and the patient was able to go home. And so that's how quickly these things can work. They're really very amazing medicines. And we've learned over time that if you take another medicine called a MEK inhibitor, and I'll show you the pathway on the next slide, if you take a MEK inhibitor here, so here's the B-RAF mutation in the pathway. This is the metabolic pathway or the genetic pathway that melanomas use to spread. So if you get the mutation here, what we found out in the very early studies was the medicine would work, but many of those cancer cells would get very smart and learn how to go from here to here and hop over the mutation. So we decided, well, what happens if we put two roadblocks? And we give a B-RAF medicine and we give a MEK medicine. Well, what we found was pretty astonishing because the two medicines work together. And they really help to control melanoma and even cause patients to go into complete remission for many, many, many years. Many of those patients, again, I say have durable long-term responses, and when I retire, I'm going to be very happy to tell them that I cured them. So these were some of the studies that showed all of the lines underneath. These are what we call waterfall plots, and this looks at MEK inhibitors, B-RAF inhibitors, and the combination. All of the bars underneath this horizontal line are patients who had good responses. So as you can see, MEK inhibitors by themselves, they work, but not so good. B-RAF inhibitors work great, and so does the combination. So, of course, everything that we have has a possible side effect, because if you read the back of an aspirin bottle, you probably wouldn't want to take aspirin either, or ibuprofen. Who takes aspirin? So what are the side effects of these medicines? They are not like chemotherapy because they're not causing immune suppression. They are shutting off a target. They're not shutting down cells that are rapidly dividing by killing them. They're just shutting down the signal. So patients can get joint pain. They can get muscle pain. They can get rashes. All of these drugs get metabolized through the liver, so we have to watch very closely and make sure that their liver tests are adequate, because everybody's liver will metabolize these drugs at different rates. So sometimes we have to stop people's medicines because their numbers get a little bit higher, and sometimes we have to lower the dose of the medicine. They can also develop what's called hand-foot syndrome, where the palms and soles of their feet get very, very sensitive. And I can honestly tell you a story that when we did the very first studies with these medicines, melanoma patients couldn't believe that we were actually making them better. And so the worst thing in the world for them was for me to have to tell them, you need to stop the medicine because you have toxicity. So people wouldn't want to tell me about their side effects. But one of the things I realized in doing the first studies is that many of my patients came to the office with their bedroom slippers. Why? Because they had palmar plantar erythema. They had hand-foot syndrome. The bottoms of their feet were so red and so sore and so painful, they couldn't put shoes on. But they knew they needed to come in because they were on a study and I was giving them their study medicine. And so it became curious to us why all of a sudden patients on B-RAF inhibitors would suddenly decide it was okay to come in with their slippers to the office. And so anybody I saw coming in, I would say to them, do you have any side effects? And everybody would say no. And I would say, yeah, but you need to take off your slippers because I bet your feet really hurt. And they'd say, yeah. And you'd take off somebody's slippers and you'd see these big, red, swollen, painful feet. Some of the medicines can also cause fevers, photosensitivity. What does that mean? It means that you go out into the sun on a day like today where you don't think that there's any sun out there. And if patients don't wear sunscreen, they have a chance that they can wind up with very, very severe sunburns. We also know that these medicines can also cause new squamous cell cancers and also cause some new melanomas. Again, patients like this are being followed very closely by myself, a surgeon, and a dermatologist. So we pick these up very closely. We don't stop the medicine. We just take off the new cancer and move on. And this is actually a picture of those really sore, painful feet. You can see big, nasty blister here, very painful for this person to walk. These medicines can also cause, they look like little warty type of growths. You can see a growth here on the nose. And again, squamous cell carcinoma of the skin. It's very important to know that squamous cell carcinoma of the skin only occurs with these medicines. Squamous cell carcinoma of other parts of the body, like invasive squamous cell, that occurs either in the chest, the lungs, that does not occur. It's only on the skin. And so let's talk quickly about checkpoint inhibitors or immunotherapy, because this is really science fiction therapy. I know this side of the room has probably seen Star Wars when Star Wars came out in 1980. But I think this side of the room probably also saw Star Wars because of the remake. So we're going to think about the Death Star. And you know, you had the big Death Star, and Luke Skywalker was out to blow up the Death Star, but couldn't because it had this big force field around it. But there was one way that if they got in and got that ammunition to where they needed to get it, that you could blow up the Death Star. Well, this is kind of how melanoma works. Melanoma is that Death Star. It's protected, and it's protected by a number of different proteins called PD-L1 proteins, and they make up that force field. So when your immune system is out there looking for melanoma, it doesn't see the melanoma cells because the force field is up. It's got this protein layer that's protecting it, these receptors that are protecting it. And so we have a medicine called ipilimumab, which was the first immunotherapy that got approved, that gets your body's immune system up and running, and it gets those T cells out there, and the T cells are the cells that are out there looking for things that don't belong. Things that don't belong are cancer cells because they're not growing at the right rate. But not everybody who gets ipilimumab had a great response. Did better than chemotherapy, worked about 20% of the time, but we couldn't quite understand why, if we got all of your immune system raging and running around and all these T cells floating around, why couldn't we do better? We couldn't do better because we got a force field. And so we developed a drug called a PD-1 inhibitor that actually attacks the force field. And so if you have protein receptors called PD-L1 receptors on the surface of your tumor cell, and now we give you a medicine that binds to those receptors and brings down the force field, guess what? Now all those active T cells can recognize the cancer cells or the melanoma cells as being things that are not behaving and go and attack it. And so interestingly, if we gave just a medicine called ipilimumab, like I said, it works about 20% of the time. If we give just a PD-1 inhibitor by itself without escalating the immune system with ipilimumab, it works about 40% of the time. But when we put the two together, if we upregulate your immune system with ipilimumab and bring down the force field with PD-1, it works between 65 and 70% of the time. It was something that we never ever imagined seeing, and so many patients are deriving very significant benefit and even long-term control of their disease because of these two medicines. And this is again showing how the two work way better than one. And so what are the benefits? Well, the benefits are, again, this is not chemotherapy. So there's no nausea, no vomiting, no hair loss, no immune suppression. We're building up your immune system. However, everything has side effects. And when you think about it, when we cause your immune system to be very active, what happens? Well, we can cause autoimmune side effects because now we've got your immune system going bananas and it's got no controls, and we take the brakes off your immune system and say, go for it. Well, what can sometimes happen is you can cause inflammation to other parts of your body, like pneumonitis, colitis being one of the biggest side effects. So side effects are the itises. Immunotherapy causes itises. So diarrhea, colitis, dermatitis, rashes, pneumonitis, shortness of breath, pruritus, itching. So anything that can be associated with inflammation is a potential side effect of immunotherapy. What's another nice thing is, again, I also didn't mention this about the B-RAF inhibitors, is that all of these new drugs that we have the potential to get up into the brain, and because melanoma likes to hide in the brain many times, it's really very, very convenient for us to have medicines that can now get up there and not only take care of the disease that's active from the neck down, but can also get into your brain and take care of the tumors in your brain as well. And these are some of the side effects that we talked about. And in conclusion, I hope I've convinced you that I now have some pretty amazing tools that we can control patients' melanomas with. Many of them provide patients with long-term, durable responses, AKA the C word that I won't say. But many patients are going to go on and actually be cured of their melanoma because of many of these medicines. I don't even think I remember how to give chemotherapy anymore, which is a really good thing as far as I'm concerned. And so we're still doing lots of research here. Why? Because we can fix 50% of our patients, maybe a little bit more, but 50% is not equivalent to 100. So until I can stand up here and tell you, we fix everybody, we're still working hard to fix melanoma. And I want to really thank all of the patients who have participated in any of the trials that we did here, because through their participation, we've really changed what happens to patients who have metastatic disease. So let's go back to our questions again. Most effective treatment for melanoma that's spread to other parts of the body is chemotherapy, true or false? How do I can't. All right. True or false? False, correct. Next. Approximately 50% of all skin melanomas that spread to other parts of the body will have the B-RAF mutation. This mutation can be transferred to other patients' family members. True or false? False. It is present 50% of the time, but you cannot give it to family members. Good. Number 3, side effects of immunotherapy are the same as side effects of chemotherapy. False. Excellent. God, I might have taught you something today. This is good. The chance of a patient with metastatic melanoma that is spread to other parts of the body living 5 years is less than 5%. False. It used to be true, but no longer true. It's very, very false now. And immunotherapy activates a patient's immune system to attack the melanoma. The treatment has a very high possibility of putting patients into remission for the rest of their life. True or false? True. Excellent. Thank you for your participation. Thank you for listening to me, and I believe I am now done. Thank you.